free to put up your physical hand. Probably easier to see the electronic hand, so we can actually see more people and ask a question or put it in the chat. But as I said, we won't record it, so don't feel shy. I will mute and I will hand over to Liz, and I think we started recording.
Yeah. Brilliant. Can you hear me?
Yes.
Good. Okay. So it just looks like I'm muted. Thanks very much, Tony. So basically, just what we'll do is we'll run through the trial again. Hopefully, you remember some of this from last year. And then I was really hoping at the end to have a bit of a discussion about things that we might try and develop in PEDS to make recruitment a little bit more successful this season. So I'll just run through that now. So this is, sorry, my moving on button is very enthusiastic. So this is, as you know, an NHR funded trial in the UK, but we have multiple international sponsors around the globe, as shown on the screen here, including colleagues in Europe and Australia and Canada, amongst others. And so this is a really exciting opportunity for us to try and finally get some good answers as to how best we should manage flu in patients admitted to hospital. And really importantly, this is one of the first trials that's included children. So I'm really excited about the opportunity to do this. This is the list of investigators from the top. So you just heard from Tony Gordon, who's the UK lead investigators. And I'm not going to go, these are the other people who are involved from the team in Utrecht in the Netherlands. And here are some of the people. So there's my very old, unfortunately I'm older now, photo. So the people you might have heard from, if you've been setting up at your study, are Aisha and Janice in particular. Emma and is also familiar. And then Ram and I are, Ram is a critical care consultant at Imperial, and I'm a PEDS ID consultant at Imperial, and we're the kind of paediatric co-leads along with Callum Semple, who's also on the trial group. So Callum's based in Liverpool. So we're the 3 paediatricians that you might come across. And all of this team are helping to run behind the scenes to make sure that we're all set up appropriately to recruit children to REMAP-CAP. So this is a REMAP-CAP, stands for Randomized Embedded Multifactorial Adaptive Platform Trial, which obviously slips off the tongue really easily. So we just stick with REMAP-CAP. The CAP bit is for community-acquired pneumonia, and this particular bit is looking at pneumonia caused by influenza. And this was funded by the National Institute of Health Research in 2022. And then really we started recruiting in 2023 winter. And it's an adaptive platform trial for patients who are admitted to hospital and who are severely ill. And the aim is to look at, provide evidence that can be used for pandemic situations. And so this is obviously very important during the COVID pandemic. And the aim is to reduce mortality and obviously try and prevent patients ending up in critical care and to reduce morbidity as well in those in community-acquired pneumonia. So this is the adaptive platform trial that we have for influenza. So for patients who meet the eligibility criteria, which we'll go through in a moment, there are a number of domains that they can be entered into, either one or all. And so the antiviral domain includes oseltamivir and baloxavir, or a combination of the two, because these are important questions to know whether these antivirals are effective in preventing progress to critical care or other outcomes, but also whether we're better off using 2 at the same time. So that is the antiviral outcome. We have a corticosteroid domain, and this is really off the back of the data from the COVID pandemic, which really showed that dexamethasone has a huge impact in preventing mortality and morbidity for SARS-CoV-2. And we want to explore if it has a similar beneficial impact for influenza, but also looking at some of the other immune modulators that were quite impactful for COVID, including tocilizumab, which is an anti-IL-6, and baricitinib, which is a JAK inhibitor. And these are specific monoclonals which immune modulate the immune response in the lung and therefore may prevent some of the inflammatory damage caused by viral infections. And this is using a Bayesian model, which is a type of statistics about which I am not going to pretend I know a lot. But it means, basically from a pediatric perspective, it means the numbers required to recruit are lower which is very important for us where our numbers are smaller. We don't have a fixed sample size. We can enroll until we get to a predefined threshold in terms of results. And this means that we can keep going until we know that we have the answer that we're looking for. And I'm not going to go into that greater detail. I'll be very happy if Tony wants to jump in there, but otherwise I'll keep going. And so we talked about CAP and community-acquired pneumonia and COVID-19. For the purpose of children, this is really just about influenza, and that is the disease state that we're interested in. And so they were adults, children over 12 and children under 12 will be the three groups that we're looking at. And this isn't just for patients in the intensive care, which is one of the reasons why it's also so exciting, because particularly we have a small number of paediatric intensive care beds, so keeping children out of intensive care is a very attractive prospect. So it also includes patients who are admitted for respiratory support due to flu who do not require a PICU admission. So that's the moderately unwell patients, which I think is a really crucial group, in particular for paediatrics. And we've just been through this. All right, so these are the three different domains that we would be cruising through. So these are the eligibility criteria, that they are a hospitalized patient, either on the ward or intensive care, and they are acutely unwell with respiratory tract infection due to flu. They are excluded if they've had a prolonged admission in hospital with the flu, or more than 2 days in intensive care, and also if it's likely they're going to die quite rapidly, because this would obviously skew results. But also if they're about to get better very rapidly. So I think if they're going to go home in the next 24 hours, again, they probably shouldn't be recruited into the trial. And then also if they've been in the study in the last 90 days, this is their second episode admission with flu in 90 days, we would exclude them. And so just the different eligibility criteria for the different domains. So you have to have confirmed flu, and this can be on a rapid test or a multiplex test or a lab confirmed PCR. So the type of confirmation is either of those. And again, they shouldn't have been in hospital for more than 96 hours. So they're kind of well established in the flu. We really want to get people at the start of their flu admission, and that's 48 hours for ICU. And then they should have only had one dose of oseltamivir or no doses of baloxavir to be included. So if they've received 2 doses already, then it's tricky to randomize them beyond that point. And they shouldn't have allergies to the interventions. And then at the moment, not relevant so much for the kids, although I suppose it could be, pregnancy is an exclusion criteria apart from for oseltamivir only.
My name is Srinivas Murthy. I'm excited to talk to you about influenza antiviral strategies within REMAP-CAP. I'm in Vancouver, Canada. I'm a critical care and infectious diseases doctor. I primarily practice in pediatrics. So I'm only going to take a few minutes. Randomized evidence for influenza antivirals in hospitalized patients. I would love for there to be any. Unfortunately, there are no fully enrolled prospective randomized trials of one of the most commonly used medications on the planet, oral oseltamivir, for hospitalized influenza patients. And so it is the year 2023. We've been using this medication for decades, and we do not have any randomized evidence for its benefit. And that's the gap that we're aiming to fill. So previously, and over the past couple of years, we've been enrolling patients with suspected or proven influenza to one of no antiviral, 5 days of oseltamivir, or 10 days of oseltamivir. We've got about 200 randomized in that domain thus far, with a primary outcome of 90-day mortality. Over the past year or so, we've amended this domain. This is what's currently active, to patients with proven influenza only. Namely, you need to have a positive test, and incorporating a new medication, baloxavir, that's approved most countries around the world for the treatment of less complicated influenza. Randomized, so the patients will be randomized to one of no antiviral, 5 or 10 days of oseltamivir, and baloxavir, and then baloxavir in combination with 5 or 10 days of oseltamivir. These arms have been added and patients are beginning to be recruited to these interventions around the world. The inclusion criteria are now patients with confirmed influenza infection, and that confirmation can be with any locally approved diagnostic test, and age greater than 28 days old. And so now we've included children in this domain. The exclusion criteria are more than 96 hours since hospital admission or more than 48 hours since ICU admission. The original intent of this domain was to focus on community-acquired infections. If you've already received 2 or more doses of oseltamivir or 1 dose of baloxavir, you're excluded. If there's a clinical decision by the clinical team that they really want to treat with an antiviral, then obviously they won't be eligible to participate. And for the baloxavir-containing interventions, pregnancy is a specific exclusion, given the lack of available data for safety. The baloxavir dosing regimen is as you see it. For adults, it's 40 milligrams on day 1 and 4, plus day 7 if the clinicians think that it's clinically indicated, i.e. the patient's not getting better. The oseltamivir dosing is for adults 75 milligrams twice daily for the duration of which they're randomized to. Children and renal dysfunction, we provide dosing recommendations, although if there are local guidelines that inform that, we aim to be pragmatic and abide by those guidelines. For pediatrics, and one of the novel aspects of this domain is that we are including both kids and adults for a common disease that affects both children and adults. And we're incorporating novel statistical techniques to learn as much as possible about the benefit or harm in children using adult data that's generated during the trial. So hopefully we'll have some child-specific evidence that can inform child-specific practice from this large international platform. And as always, I do always want to emphasize the global and collaborative nature of REMAP-CAP. We have sites on every continent and patients recruited from every continent, and we're excited to continue to engage with the larger community. Thanks.
Great. Good. Oh, my. So this is the corticosteroid eligibility. So they need to basically be in oxygen and recently arrived into intensive care if they're severely unwell, without a desire to give steroids for an unrelated condition. I think this will probably go into this video.
Hi, my name is Derek Angus. I am the chair of the corticosteroid domain for REMAP-CAP, and I'd like to just briefly go over some changes to this domain. By way of background, REMAP-CAP is addressing, broadly speaking, the question of whether corticosteroids help patients hospitalized with severe community-acquired pneumonia. This remains a question for which the answers are unclear. We have demonstrated benefit in severe COVID-19, but it's not exactly sure if there would be benefit in other types of CAP. There have been numerous randomized controlled trials and meta-analyses, but these results have been inconclusive. Some suggest benefit tending to be in sicker patients, but there are also adverse effects. And so some of the key unknowns that REMAP-CAP was already designed to address include, should steroids be given for CAP due to influenza? How should dosing of steroids be given if the patient also has concomitant septic shock? And what to do if the patient has not just CAP, but also ARDS? There are 3 other questions that we would like to embrace in the design. One is, which corticosteroid should actually be used? There's evidence for benefit with both hydrocortisone and with dexamethasone. It's also unclear whether corticosteroids should be given to children with severe CAP, severe influenza. And It's also unclear what to do if the patient is sick and admitted to the hospital, but not so sick they're admitted to the ICU and meeting the severe state criteria. And so we've implemented 3 changes to the corticosteroid domain. First, we've added a new intervention, fixed course dexamethasone. Second, where sites have got approval for the updated core protocol, the domain can now be open for patients in moderate state, i.e. patients who are not receiving organ failure support in an ICU at the time of enrollment. And third, we've extended the age limit down to 28 days. In other words, children, other than neonates, are now eligible for enrollment in REMAP-CAP. So the changes to the inclusion criteria are children from the age of 28 up through all of adult life. And if enrolling patients in the moderate state, there is one proviso, which is that they should not only be hospitalized, but they must be receiving some form of supplemental oxygen by face mask, low or high flow non-invasive ventilation, for example. The exclusion criteria remain essentially unchanged: known hypersensitivity to any corticosteroid, intention to prescribe systemic corticosteroids for a reason other than CAP. For the severe state patients, if they've already been admitted to the ICU for more than 24 hours, and if the clinical team believes that participation in this domain is not in the patient's best interest. In terms of something about these arms, so there's now essentially 4 arms that someone can be randomized to: the no corticosteroid arm, the fixed dose hydrocortisone, which is a 1-week course of IV hydrocortisone at 50 milligrams Q6, also the shock dependent hydrocortisone, which is IV hydrocortisone also at 50 milligrams Q6, but only while the patient is in shock. These doses, these arms all existed before, and now this new arm of fixed duration dexamethasone, which is IV or enteral dexamethasone at 6 milligrams daily for 10 days, but with dose adjustment for pregnancy, and also in children, it is weight-based dosing. As always, if you have any questions, you can reach us at www.remapcap.org. Thanks so much.
Great.
Hi everyone,
Sorry. Oh, I'm not very good at tech. I'm really sorry. Let me see if I can. So this is just about the immune modulation domain.
Hi everyone, my name is Tom Hills. I'm an infectious diseases physician and clinical immunologist in Auckland, New Zealand. I'd like to talk to you about the influenza immune modulation domain, a new domain in REMAP-CAP. And this domain is approved here in New Zealand, it's approved in the UK, and we're excited to see more and more regions coming on board. Here we're looking to build on knowledge from the pandemic and apply that to other viral infections and evaluate whether these therapies, tocilizumab and baricitinib, which are effective in severe COVID-19, are effective therapies in severe influenza. The reason we're interested in doing that is that there are similarities in terms of the immune response in patients with severe COVID-19 and severe influenza. Interleukin-6 is a critical cytokine in that host response to these severe viral infections, with IL-6 levels being highly elevated in both severe COVID-19 and severe influenza patients. High IL-6 concentration associated with disease severity, mortality, inversely associated with arterial oxygen levels in hospitalized influenza patients. It's not clear whether those high IL-6 levels are a marker of disease severity or a mediator, whether that IL-6 is involved in the pathophysiology of severe influenza infection. Because of the findings in severe COVID-19 patients, we're very interested in evaluating these immune modulatory therapies in severe influenza. So we propose evaluating no immune modulation versus tocilizumab versus baricitinib. Tocilizumab will be familiar to many of you as an intervention that was studied in the IM1 COVID-19 immune modulation domain, where many patients were recruited from the UK, and it was evaluated alongside a similar IL-6 receptor antagonist called sarilumab, and both were shown to be very effective treatments for severe COVID-19. Baricitinib is also now widely used as an approved treatment for patients with severe COVID-19. This is another medicine that we're repurposing from the outpatient clinical immunology rheumatology world, where it's used for autoimmune diseases and atopic diseases, and it inhibits the downstream signaling of cytokines like IL-6. It's also effective in severe COVID-19, as demonstrated here in a figure from the recovery trial. So our question is, does treatment with these immune modulators, tocilizumab or baricitinib, improve outcomes for critically ill patients with severe influenza? The inclusion criteria reflect the approved use of tocilizumab and baricitinib in severe COVID-19. So we're constraining this to patients who are at least 2 years old. They're in the severe state of REMAP-CAP, so critically ill receiving organ failure support. Influenza virus infection has been confirmed by microbiological testing, and influenza virus infection is the reason the patient's in the severe state, rather than they're in a critical care unit with trauma and happen to have influenza. We exclude patients who have SARS-CoV-2 infection because these agents would be standard of care for those patients. And then we have some other exclusions, again, based on the use of these drugs for COVID-19, such as significant immunosuppression, an invasive infection with something like a bacteria or a fungus, or people have already received these drugs or a related drug. Importantly, if patients are pending the result of an influenza test, they can be enrolled, and then their treatment assignment can be revealed once those test results become available. We understand that some patients may be enrolled in the platform and receive treatment allocations in other domains where the influenza testing information is not required, and this domain is something that they can be enrolled in, and their treatment assignment can be revealed using a delayed reveal when the influenza test result becomes available. Dosing of tocilizumab is as given for patients with severe COVID-19, 8 milligrams per kilogram up to 800 milligrams for adults, and we're giving a single dose. A minority of COVID-19 patients in studies and in clinical care may receive a second dose, but we're evaluating a single dose here. Pediatric dosing is the same as adults for children who are at least 30 kilograms, but children who are less than 30 kilograms have a 12 mg per kg dose. And again, this is in keeping with the approved dosing for COVID-19. Baricitinib is an enteral medicine, and its dose depends on renal function. So there are some EGFR bands there, and this reflects the dosing used for COVID-19. And in children who are at least 9 years old, adult dosing is being evaluated. And in children who are less than 9 years, as with clinical use of baricitinib for COVID-19, we use a slightly lower dosing. The primary endpoint will be the same as for other domains in REMAP-CAP as defined in the core protocol. Important secondary endpoints for this domain include positive blood culture results for bacteria or fungus that identified more than 48 hours following randomization. And pulmonary aspergillosis diagnosed more than 48 hours following randomization. There were not significant safety concerns in terms of secondary infections when these drugs were used for COVID-19, but influenza is different, and there may be higher rates of co-infection in patients at baseline, and we felt it was prudent to collect information on secondary infections using this definition of blood cultures and pulmonary aspergillosis as key clinically relevant infections, and we want to evaluate whether there is any increased risk with these agents, contributing more to the data on the safety of these drugs in critically ill patients with viral pneumonia. I'd like to thank you all for your time and for your interest in this domain.
Great. So hopefully that was a nice reminder of the domains involved in REMAP-CAP. And as Tony said, this is going to be recorded so people can go back to it later if they wanted to remember it more. So what did we do last flu season in pediatrics? So we have a relatively low recruitment to screening rate. So there were 64 patients who were in the pediatric group who were screened, of whom we recruited 12. And there are 11 sites currently open nationally to REMAP-CAP. So just thinking about this, it would be really great to see whether we can open more sites in the first instance, but also think about why some of these patients were screened but not recruited. And it would be great to have feedback from people about any patients that they can remember or reasons why they think it's difficult to recruit patients to this trial. So from my perspective, I know that we had a couple of patients who came in with to intensive care who'd actually come in with seizures, which is not an uncommon presentation in paediatrics with flu, and therefore they didn't actually have respiratory compromise, so they were intubated and ventilated for status epilepticus, but not with an oxygen requirement, and weren't unwell from that perspective. So we didn't recruit them because it wasn't appropriate. But it would be good to think about other reasons. So these are some of the ones that the team have very kindly pulled for me from the screening log. So prior treatment of oseltamivir with 2 doses. And the common one, one that we often see obviously is declined consent by the family, or the seizure one would come under the not best interest from the clinician. Because there was a decision to treat them rather than to put them into a trial. And then I think that there are quite a lot of children who were admitted who didn't require supplemental oxygen, so they weren't eligible for the corticosteroid domain. Just an update, if I can go back to it, on baloxavir, because I know there were lots of discussions about this last year. Because we don't yet have the strawberry flavoured formulation from Roche. But once we do, that'll make it much easier. At the moment, we have to dissolve baloxavir in quite a large volume of liquid. So at the moment, we can still only really recruit patients who've got a nasogastric tube or who would be able to swallow tablets into this intervention. And so that remains the same status as before when we were recruiting. And then I'll just take any questions. I can't see any hands going up or anything in the chat. Aisha, is there anything?
I can't see anything in the chat. If people want to put their hand up, please do.
Okay. Nope. All right. Aisha, am I handing back to you?
I guess we'll just move on, and then there will be a chance for questions at the end as well.
Aisha, one hand has gone up.
Oh, okay. Yep, sure.
Is it Farhana? Is that?
Yes, sorry. We just had a question about giving baloxavir via NG. What if it's a small baby and you need to give a large volume?
I guess that would be a clinician decision on
if they're fluid restricted. That's the only thing we're worried about.
So we just have to look at the volume and make a discussion with the team on whether or not that's an appropriate thing to do. Okay. So we can, very happy to. I think that would just have to be a case-by-case scenario.
Okay, thank you.
Do we have any other hands up? I think there's something's just come up in the chat, it looks like.
It's about the stock. And Aisha, do you want to tell them about the stock? I know there were issues being replaced in the pediatric formulation. Is not yet available, but we're hoping soon, isn't that right?
Yeah, so we've just chased it up today with Roche, and they said they'll get back to us. They're just chasing up internally.
So hopefully we'll be here before the flu cases really start coming in.
Yeah.
We've had a couple already.
So do you have stock of the tablets? We've been told there wasn't tablets either.
No, there's no tablets either at the moment. But the manufacturer is due to receive a new batch. So we're just waiting for a response regarding that.
Okay.
Were you okay to move on?
Thanks. Yeah.
Yeah. Okay. So just a reminder, in regards to matrons as professional legal representatives, during the Substantial Amendment 41, we put this through so that we can allow matrons to now act as pro-LARs, and that should help with issues where sites don't have enough doctors to be eligibility checkers for this. In terms of consent documents, we do have a slight change in our processes where we will be localizing PIS and consent form documents on behalf of sites. This is as per the sponsor request, and it is because we have various sections in the PIS that may require deletion or amending, depending on which interventions sites take part in. and just to avoid any sort of mistakes and things being made. So we would likely request logos and headers so that we can add those in, and any sort of local contact details. And then we'll make the adaptations required and send sites a PDF locked version of that. Translated PIS documents will be available following the next amendment, so those aren't available just yet. And here we've just got a consent animation for video consent, and then I can explain how we use that. I can't actually see. Oh, I think it started playing. Everyone hear that?
Yeah.
Research is how healthcare professionals find out the best way to treat illnesses or health conditions. Most hospitals and many healthcare professionals are involved with research. It's an everyday part of what we do. GPs, doctors, nurses, physiotherapists, pharmacists. Everyone wants to make the care better for people who need it. All research is looked at by an independent research ethics committee who check that it is okay for people to take part in. Taking part in research may or may not help the person taking part, but it will help healthcare professionals learn more about the best treatments of people who have the same illness or condition. We will only ask you if you would like to take part in research if your doctor says it is okay for you to take part. A research nurse will talk to you about the research and you can ask questions about it. If you say yes or no, it will not make a difference to the care you receive. You will still be looked after by your healthcare team. If you say yes, you will be asked to sign a form called a consent form to show that you want to take part in this research. Even after you've signed the consent form, you can still change your mind and say you no longer want to be part of this research. Sometimes people are too ill or not able to understand the research to say yes or no. Then someone close to them, a family member or friend, will be asked if they think that the person would like to take part in research. If there is no friend or family member able to talk to the research nurse, then an independent doctor who is not part of the research study is asked to say yes or no. As soon as the patient is well enough and is able to understand the research later on, they'll be asked if they want to stay in the research study, and they can say yes or no. This video is about a research trial called REMAP-CAP. This research trial is happening in 150 hospitals in the UK and in more than 300 hospitals around the world. It is looking at which medicines will most help people when they're in a hospital for pneumonia, flu, or COVID-19. Research has already given us some information about what might help treat people who are in hospitals with lung infections, flu, or COVID-19. But we need to know more, especially as new medicines have become available. This research is called a platform trial. This means that several different medicines can be tested at the same time, and we can find out which ones work best and stop using the ones that aren't helping people with lung infections. New treatments can also be added. If you join this research, a computer will select one or more treatments for you. This is called randomization and means people are put in a group by chance, which allows us to compare different treatment groups. Are you ready to make treatment better for people with lung infections? Speak to a research nurse to find out more. If you agree to being part of this research, you'll be asked to sign a consent form and given a copy of it along with a privacy notice.
Okay, so that's the video we have, and then here we've just got the video consent process outlined. So the patient or the personal legal representative should be provided with the opportunity to watch the video, and then a nurse or clinician should provide the patient with the full PIS on paper, highlighting the interventions that are available and giving them the time required to consider this. And then they can ask questions, and then they should sign the video consent form. But it's just very important to note that they should still be given a paper copy of the full PIS and as well, in addition to this. So we are encouraging sites in general to play the video in waiting rooms, whether it's on staff iPads, or the link can be sent to patient relatives. Soon in the next amendment, I think we are planning on adding the QR code to the PIS so that patient relatives can just scan the QR code and the video will come up. Just going on to the antiviral swab guide. So in the flu strata, we do have swabs that are needed for the antiviral domain. So these are required on days 1, 3, and 7. We do provide all the equipment required for this, so we will send sort of like a package of swabs, tubes, and the barcode labels that goes with each time point to sites. I think we have safe boxes, but the labels currently need replacing. So I think some sites who might already have the safe boxes, we've got a new lab address, so we can send replacement labels for those. And then if you run out of or have any sort of expired bits, if you just let us know, we can send some more to you. We also have our sort of swab tracker, which is available on our website to download. And if we just remember to also fill in the details on the study database as well. So day 180 follow-up, this is completed at site for all flu strata patients who have consented to the follow-up. And it's applicable to all the domains, so steroid, antiviral, and immune modulation. Questionnaires will be different to those that are given for the adult ones. And this will be updated on the database early next year, we think. So we now have electronic training logs, which should make things a bit easier in terms of staff training. It can be accessed on our website. And then once you sort of complete the log, you should receive an email, and we just ask for that email to be forwarded to us. This just allows us to identify that you are the person that has completed the training and someone else hasn't done it on your behalf. On Spinnaker, there are quite a few yellow banner alerts, and these should be resolvable. It depends what sort of actions you have at site that you might need to complete. If there's anything that you're not sure about, if you just let us know, and we'll be able to help you out. I think if there have been any sort of erroneous alerts, we have tried to close them ourselves sort of first. Just a reminder of our website, we have separate pages for adults and pediatrics. We have our training materials on the websites, and then we also have the consent animation, the REMAP bites, our newsletters. We do have a document version tracker, which we try to update regularly, as well as our publications and FAQs. And then this video should also be on the website soon as well. In regards to funding, the study will continue to run this winter. We're just currently awaiting confirmation of details from the NIHI in terms of the extension. And then once we have this, we will submit to ethics and forward to sites as well. We do plan on having regular Q&A sessions, sort of monthly, similar to last year, where sites can drop in and just ask questions that they have, or we may have focus sessions depending on any suggestions that we might receive or any sort of common queries that we might see across sites. Yep, so just let us know if you have any questions. We've got our email address here, which I'm sure you all have, as well as the website. And I think that's it.
Thanks. I should